And have I think Amy just started. Okay, just a second here. Now I can continue. Um, so at the parking lot, it will be an unmoderated conversation. People are free to make announcements, ask questions, talk to each other. However, I'll stay on till 7:30, and so will Amy, but she just won't be moderator anymore. And it's possible that media will be present at some point, not now, but maybe later. And that's about what I remember to do. What, did I forget anything, Amy?
Neil, you did a perfect job. Thank you so much.
So now I'm turning it over to Amy, who is the moderator for tonight.
Thank you, Neil, and thank you everyone for joining us this evening for our May Courageous Conversation. This evening, our topic is Black maternal health, risk of becoming a mother. So we have a few video clips for you. We're going to start with the first one, which is, it deals with the question, why are Black mothers and infants far more likely to die in the US from pregnancy-related causes? And then we will open the floor for discussion. Our next video is centered around a women's group in Memphis and how they're working to address racial disparities. And then we'll dig down into the conversation about the importance of breastfeeding, et cetera. So that is how the segments of our evening will go. I will share my screen and start with our first video clip.
An American tradition continues. Join me.
I was hoping we would avoid the intro, but it'll be over in 20 seconds and our video will start.
And it is one that has been getting worse. The U.S. is one of only 13 countries where the death rate is worse now than it was 25 years ago, and among the worst of the wealthiest countries in the world. Between 700 and 900 American women die each year from problems related to pregnancy, childbirth, or complications, up to a year later. There are as many as 50,000 cases annually where women face dangerous and even life-threatening situations. As part of our ongoing series, Race Matters, Amna Nawaz looks at why it is dramatically worse among African American women. It's the focus of this week's segment, The Leading Edge.
And the statistics are stunning. Black infants are more than twice as likely to die than white infants, a racial disparity that's wider today than in 1850, 15 years before the end of slavery. And Black women are 3 to 4 times as likely to die from pregnancy-related causes than white women. For a closer look at what's behind those numbers, we turn now to Linda Villarosa. Her in-depth report on the subject ran New York Times Magazine, and Monica Simpson, Executive Director of Sister Song, the country's largest organization dedicated to reproductive justice for women of color. In 2014, she testified before the United Nations Committee on the Elimination of Racial Discrimination. Linda and Monica, welcome to the NewsHour. Linda, I'd like to start with you. Help us understand these numbers. What is going on in America, in the lives of Black women, in our medical communities that's causing this?
Well, what I found in my reporting were really two things, both related to race. The first was that simply the experience of living in America as a Black woman does something to your body that causes low birth rate babies, that causes maternal mortality, that causes infant mortality. Second is that there is a kind of racism in the healthcare system, and most of it unconscious. It's a kind of bias that's existed for a long time that we've known about that is affecting the birth experiences of Black women in America.
So, Monica, let me ask you now, because this conversation about the black-white disparity, it's long centered on things like wealth and education, right? The idea being that poor or less educated women are more likely to have negative outcomes. But then last year, we all heard the story of Serena Williams, right, who had her own very serious complications during her delivery, and she shared them very publicly. That turned the conversation on its head. Is that kind of experience more common than previously thought?
Unfortunately, it's very common. And what is so critical about this issue is that we just came out of Black Maternal Health Week, the Black Mamas Matter Alliance that got birthed, from this report and work that we did, that we took to the UN. We were actually picking up stories like this and hearing this across the board from so many Black women across this country, that it didn't matter what their socioeconomic status was. It didn't matter, what their education level was. Here we are looking at Serena Williams in particular, who was the world's, best athlete. She definitely has support. She's definitely not dealing with, economic issues. And she still was dealing with the fact that she almost lost her life after giving birth. This story is just, we can see the thread, right? From her story and to so many women, Black women across the country. Unfortunately, their outcomes were still just not, they were not to par.
Linda, I want to dig into something you mentioned about the other things happening in women's lives. In your report, you tell the story of a woman whose daughter is stillborn. Her medical story, at least, begins and ends with sort of the pregnancy and the delivery. But in your report, you trace her story back much, much further. Tell me why that's important, why understanding of that complete story is necessary to understanding why things end up the way they do.
I think what her story told was really a story of empathy. So you could really understand what women go through during pregnancy and childbirth. And her baby died, and she almost died in 2016 from preeclampsia. And that is high blood pressure during pregnancy. And so when she ended up getting pregnant again a year later, she was terrified. And so she really needed a lot of support because she was very much afraid of coming home empty-handed again. And I think telling that story really is a story of humanity. It's a story of resilience, and it allows people to really understand what is happening in the lives of Black women today.
And you used a couple of phrases in your report. I'd love for you to explain toxic stress and weathering. How do those work in the context of this conversation?
So when you hear the word stress, you kind of think of, oh, I feel really stressed out, or I just need to kind of take a chill pill or relax. But really, toxic stress is the result of aggressions that happen to you and insults that happen to you. And in this case, race related, it can be everything from, I feel that I'm treated differently, people think I'm less intelligent, to I am being discriminated against by the police in housing and in my workplace. And those actually, it's been proven that those have a physical effect on the body, because every time you get stressed out in this way, and if it happens repeatedly, all of your systems fire up. And if your systems continually fire up, they break down. And weathering is the idea that your body, because of these repeated insults and this repeated firing up the system, the body ages prematurely. And it's not on the outside. I mean, it could be, but it's on the inside. And that all comes to a head during what is essentially a stress test of a woman's body, and that is pregnancy and childbirth.
And Linda, when you say that it's been proven, I want to be clear about this. Linda, in your report, you talk about the body of evidence, of statistical evidence that traces back years and years. Tell me about that.
One thing how I learned about it, specifically in infant mortality, how I learned about the discrepancy between that an educated Black woman has a higher chance of her baby dying than a white woman with an 8th grade education was in 1992, when one of my professors in grad school handed me a study that had this kind of data in it. And it was in the New England Journal of Medicine. And I argued with him, and he said, no, this is real. And I went back and talked to one of the women who was an author of that study, several months ago. And she had collected 174 studies that were saying similar things, whether they were about race in the body, the effect of race on the body, or the effect of race in healthcare. And I said, my gosh, you have 74 footnotes here, 174 footnotes. And she said, you have to prove things. You can't just say it's race. You have to prove it. So this is a thing.
So, Monica, I want to ask you about this now. There is obviously the lived experience that contributes to this. And there's also, as you mentioned, what happens, or what we now know happens by and large, to women of color, particularly Black women, inside the healthcare system. You've testified about that racial disparity before the United Nations. What, if anything, is being done to address that so far?
Absolutely. One, we have to address the fact that we have, lack of Medicaid expansion in this country, and the lack of access to healthcare is still huge. In the South, overwhelmingly, we saw that we didn't see an expansion of Medicaid. So thousands of people are still left without access to their basic healthcare. We also looked at the fact that, unfortunately, we are still dealing with abstinence-only education that doesn't give a comprehensive, overview for folks, for them to understand their bodies and what happens to their bodies, and to help people plan and think about what they want for their lives. That is also very critical to this. And then thinking about the fact that research is still needed, right? We still need to get accurate numbers and continue to feed these statistics and let people understand the fullness of this issue. And then that will help us think about how to move this in terms of policy, and making sure that our elected officials understand that we need to have this handled, right, in our policies. And we need to move forward with proactive legislation that helps us get on the front end of this, to see these numbers decrease. And so from bringing those stories from on the ground, the statistics are real, and so are the stories from so many folks who have experienced oppression, they've experienced discrimination, within the system.
Linda, you mentioned the conversation over 25, 30 years ago. Now, today, what do you think is the next thing that needs to happen to alleviate that disparity?
I think that what we have to do is change the medical system. Something is deeply embedded, a kind of I don't want to say individual people are racist. Maybe that is part of it, but this is something that's embedded in the system. It's baked in, and we have to, starting at medical school and before, to start getting doctors to face, and other medical providers to face, unconscious bias that is affecting the care that women of color and everyone receives in the healthcare system. So I think that's a very, very important first step.
Linda Villarosa, Monica Simpson, thanks for your time.
Thank you so much.
Thank you. Thanks.
All right. So I will put the link to that video in case you want to watch it again or share it with others. But at this point, we'll open up the conversation. So a lot was discussed in that clip. They talked about toxic stress and weathering, how unconscious bias in the medical system produces these negative outcomes for Black maternal health. If you would like to share, please put a question mark in the chat and I will know to call on you, and you can unmute yourself. If there is something that you want to share but don't want to do it publicly, you can, of course, direct message me and we will address the content but not associate your name with the comments. So the floor is open. Go ahead, Jen.
So I just turned 50, but when I was 40, I gave birth to our twin boys. And I had preeclampsia afterward and almost died. But it never entered my mind at that time, am I going to be getting good quality care? Like, I was given the best care and the best treatments. And when I started hearing stories about Black mothers either dying or at a disproportionate rate, or their children dying, it hit me hard, because it's scary enough to go through, but then to think, because if I'm Black, I'm not going to receive as good of care as if I was white. Like, that's heartbreaking. So
Jen, thank you for sharing that. Steve, I see a question in the chat. Go ahead.
Yeah, a bunch of us were involved with the Beloit Life Course Initiative for Healthy Families. It was about 10 years ago, or earlier that it started. Angela can certainly speak to it. And I think the biggest frustration was trying to get to the stage of doing anything about the disparity, of getting government or entities to acknowledge it and try to set some kind of benchmarks toward, can we measure our progress on this, or are we not making any progress on it? And so it was kind of a frustrating experience in terms of all the things to confront. And the one speaker that they had on the PBS program, indicated dealing with it within the health system, but it's got to be dealt with in the society at large. And until we confront the racism that exists, that toxic stress isn't going to be alleviated.
Thank you, Steve, for sharing that. And I think, as with many things, it's a two-pronged approach. Our society as a whole needs to work to eliminate racism, but specifically, there are things that can happen in the medical care system that can mitigate some of those racial disparities. So I see a couple items in the chat. Diane, no, we're not saying that Black mothers without insurance will not receive care. We're just pointing out that the level of care may differ, whether you're a Black mother or a white mother. And then also those health outcomes, a lot of that has racial implications for Black mothers. So the things like toxic stress and weathering, low birth rates, premature children, all of those play a role in the health of Black mothers and Black babies. Katie put a message in the chat. Are health systems in the area doing any implicit bias training? I think that's a great question. I know that SSM Health, Megan Tim, is working to get some cultural competencies and racial competencies embedded in the training there. So she would be a great resource to reach out to, and she may be able to direct you to other administrators in health systems so we can begin to ask those questions. Mary, go ahead and unmute and share your comment or ask a question, please.
Okay, yeah. I've been doing a history project that had me chasing down the path of the history of the AMA. And I stumbled across an article from 2008 when the American Medical Association issued a formal apology specifically for a history of systemic exclusion of Black physicians from the AMA and its constituent societies. And digging further in that, in 1910, the American Medical Association commissioned a report of all the medical schools, and they deemed every Black medical school substandard and recommended they all be closed, except for 2. So between 1910, well, for 100 years, it was a real struggle for African Americans to break into the medical profession. They had a hard time getting training. They had a hard time getting hired. If they did get hired, they couldn't join the AMA. And so, yeah, when I ran across this, I spent a lot of headbanging that afternoon, just saying, this is so horrible. And it helped me understand just how white focused the medical profession is, and not necessarily any one person in it, but there are forces that have just really shut out other experiences. And I can go on and rant for a long time, so I'm going to shut up now.
Well, Mary, thank you for unmuting and sharing your comments. You feel free to unmute at later points in the conversation and share. And if you have kind of access to those documents that you were speaking of, I encourage you to drop the links for that in the chat. Our chats always become a robust depository of information, so we appreciate that. So Beth in the chat, I'm just repeating because I'm not sure if everyone has it open, has offered to connect individuals with Meg and Tim, if that is something that they are interested in. Gina, thank you for dropping the link for the Black Women's Wellness Center. Great information there. Other comments or concerns? Were there things in the clip that surprised you? Information in the clip that affirmed your beliefs or things that you were already aware of?
Hi, Amy and everyone. We did have an infant mortality group here in Beloit. Steve mentioned it. It started in 2011, 2010, and lasted until 2013. And it was first funded by the Wisconsin School of Health through a grant, and it was sent to us through the State Line Community Foundation, and Tara Tender was the administrator of the grant. We were able to find exactly what that clip showed, Amy, to be true in Beloit as well as Rock County. So we started with a great deal of resistance from the medical community. Many had not heard the study, did not believe the study. They felt that we were blaming them, and none of that was the truth. But I guess at the very beginning, you would expect those things to manifest itself. So our goal was to work on racial justice and training. So we provided quite a few trainings to the community, as well as we formed a group of collaborators based on the multidisciplinary team model. We had professionals at the table, Rock County Health Department. We had community members at the table who had been affected, who came from those communities that we mentioned who were most affected. We had women at the table who had lost children. We adopted a child. Ryan was our adopted child. It was Michelle's daughter, because Michelle fit every criteria. She had a master's degree, was working on another master's, had this premature infant who was in the NIC unit. And she had volunteered with us, etc. So we watched Ryan's progress every month, and we had a huge poster of her monthly to show her progress, etc. So our job was awareness, and that took forever in order to let the disciplines know that this was an issue, that racial bias and systemic racism was a part of this, that the allostatic load that Black women felt all the time was a part of this, and women who achieved a great deal in corporate America, for instance, had a greater allostatic load, who achieved a greater attainment of education, often had a greater allostatic load. Many times they were the one, the only, and that brought with it also challenges. So we uncovered a great deal during that time and provided a great deal of training and awareness. I'd like to say that the HERE group is modeled after our group, except I'm not sure of any people of color on that HERE group, but we were able to get lots of people of color at the table to discuss infant mortality. Thanks, Steve, for bringing that up.
Angela, thank you so much for sharing. I think I've seen a couple of those posters with Regina and Ryan. And Ryan is such a bright and beautiful, talented little girl, and you never would have known she got here early. So we are all so excited for that. And glad to hear about the wonderful work that was done with the infant mortality group. Just as note about the clip that we just watched, they were talking about, we just came off of Black Maternal Health Month or Week. That was a clip from August of 2020. So if anyone is interested in doing something particularly celebratory for Black Maternal Week, it is the 3rd week in August. So just wanted to put that out there so everyone could be aware. Are there others that want to share about the health disparities outcomes before we move on to our next clip, which is centered on a group of women in Memphis? And it talks about midwifery and the importance of doulas and not in competition with OBGYNs, but working in partnership with them to really secure positive health outcomes for mothers and babies of color. So it is last call for this clip that we just viewed. If there are no takers, we will move into our next clip. Oh, I see, Shirley, you have your hand up. Please go ahead and unmute.
Thank you. Thank you. Thank you, Steve and Angela, for bringing up the infant mortality group that I think did make some pathways in addressing African-American infant mortality concerns in the community. One thing that I think Steve mentioned and Angela also referenced it, the systemic racism and the biases, the implicit bias that's here. I don't think we can leave that out of the conversation as we continue to move forward. It seems to be a thread through all areas, but again, as it mentioned in the video, and I believe Angela mentioned it, and Steve may have referenced it too. Pregnancy is one of the most taxing systems on a woman's body. And if you're dealing with people treating you inferior during that period of time, it's not a welcoming environment. And for me, particularly in listening to all of this, in the past, women were serviced primarily by midwives or someone that looked like them because they weren't even welcome in a medical community. And then the medical community found a way to make it more profitable that people actually deliver in a hospital. And the numbers changed, even though there were concerns about the number of Blacks birthed. It increased a lot when we changed the system. And most of the babies were not delivered by someone who looked and cared for a person who was Black. Thank you. And again, Amy said we're going into the next segment. I more than likely will have something to say then because they're talking about doulas and midwives. Thank you.
Well, absolutely. Please do continue to share.
The United States is in the midst of a maternal health crisis. In fact, women in the U.S. are more likely to die from pregnancy-related complications than in any other developed country. For Black women, the reality is even more startling. Their death rate is 3 times higher than that of white women, and Black babies are twice as likely to die before their first birthday. In tonight's signature segment, we bring you a report from Tennessee about one clinic that is trying to reverse that trend, one woman at a time. NewsHour Weekend's Yvette Feliciano reports in our ongoing series about poverty and opportunity in America, Chasing the Dream.
I mean, I'm excited, but nervous. Yeah.
Expectant mother Brittany Briggs is nervous.
I'm just worried about the pain. You know, I'm just not 100% sure about my pain tolerance.
A year ago, she wouldn't have had the opportunity to express her concerns in a setting like this. It's group prenatal care, led every month by midwives Nikia Grayson and Jody Lynn Owen.
And then I saw it.
The women are meeting at Choices, a privately funded reproductive health clinic in an underserved area of Memphis, Last year, Choices began offering midwifery care. Midwives here have already delivered 11 babies, with 19 more on the way.
We want you to leave our care stronger. You know, we want you to leave our care knowing how you should be treated, that you are valued.
Nikia Grayson is certified as both a midwife and a nurse practitioner. She also has masters in public health and anthropology. Grayson first studied infant mortality in the Black community as a graduate student.
In these families, the loss of a baby was almost normalized. Of course, they grieved and it was very heartbreaking for them, but it was generational. What I found was lacking was access to care and then the type of care they received and how they didn't feel valued or heard.
Before the 1900s, many birth attendants across the South were Black midwives. Now, less than 4% of U.S. midwives are Black.
It was taken away from us in our community. These are our traditions and we're taking them back.
Grayson is one of only 8 nurse midwives in Memphis and one of just 2 Black midwives in this predominantly African-American city. In Memphis, within the first year, African-American babies die at a rate 3 times higher than that of white babies.
I think that what we are now seeing is a demand for quality care that is sensitive to people's cultural needs, and the idea that the system needs to change in order to prevent these maternal and infant mortality outcomes that we're seeing. And
African-American women are more likely to experience poverty and lack insurance, which puts them at greater risk for poor maternal and infant health outcomes. But racial disparities persist, even for Black women who are college educated, according to a study in the New England Journal of Medicine and an analysis by the New York City Department of Health.
There's something wrong with the system when African-American women who are college educated and have great jobs can still have poor outcomes than white women who are uneducated.
Last year, the American College of Obstetricians and Gynecologists acknowledged that the racial and ethnic disparities in women's health, including higher rates of preterm birth and maternal mortality, cannot be reversed without addressing racial bias, both implicit and explicit.
The racial bias when it comes to Black women that are having babies is hidden.
Dr. Kia Pinkney is an obstetrician at Regional One Hospital in Memphis. She says categorizing and diagnosing patients according to their race is part of American medical practice.
That bias means it's kind of like we have shades when we're looking at this patient. So she's African American, most likely is preeclampsia. And so that prevents us from thinking of other differentials of what it could be. Could it be a migraine, or could it be just a headache because she didn't sleep last night because she was up with all her children?
The truth is that Black women are less believed when they have symptoms that are concerning, from pain to shortness of breath to other things that are really concerning.
Dr. Neil Shah is an obstetrician and professor of obstetrics at Harvard University. There is research backing him up. Several studies, including from the University of Pennsylvania and in the New England Journal of Medicine, found that Black patients with the same symptoms as white ones receive less pain medication and are referred to specialists less often.
My biases can change the decisions that I make, but it also affects the person across from me because she can see plainly what I'm not. And so as a result of that, she feels like I'm not responding to her needs, and she's not ultimately getting what she needs out of the care that I'm trying to provide. And it leads to this sort of vicious cycle of distrust.
In a national survey of over 2,000 women, 21% of Black mothers reported poor treatment from hospital staff, which they attributed to race, ethnicity, cultural background, or language. Just 8% of white mothers reported similar poor treatment. Grayson has heard about poor treatment over and over again from her Black patients and how it has created distrust and other barriers to care.
One patient talked about how her pain was not managed well when she was in labor, and that she didn't feel that they believed her when she said she was in pain. Others had Child Protective Services called on them if they express, feelings of depression, and that keeps people from coming back to care.
That bias, coupled with short patient visits, means obstetricians can have a hard time digging into root causes of a patient's problems, says Dr. Pinkney.
I don't necessarily have the time to sit there and do the educational component or the preventive things. I don't have the time to sit there and say, so how are you doing today? Tell me about your kids, and really building that relationship.
I think we have to have a more thoughtful way of thinking about the way that our biases are structured into the system, from the way that we do informed consent to the way that we interact with patients every step along the way, from intake, from triage to nursing to the care team.
He didn't like that.
No, he fights back.
And that is where midwives Grayson and Owen come in, working to counteract that bias and reestablish trust through midwifery care. As certified nurse midwives, they are trained in the full spectrum of low-risk gynecological and obstetric care, short of surgery. In addition to physical checkups and tests, they also address their patients' mental, social, and emotional needs.
All of our visits are an hour long. I want to get to know who they are as a person and what's important to them and what their daily life is like. So we talk about family and stress and what makes them happy.
And the emotional support and the physical support, because
Midwife Jody Lynn Owen says the goal is to build relationships with women, allowing them to see and deal with warning signs before they become urgent medical issues.
It is through listening that we start to understand challenges she's facing that can convert a non-pregnancy issue into a pregnancy emergency. So if we allow hypertension to develop, it will develop into preeclampsia. So in our model, we're saying, I see you are developing this. I'm going to intervene using the lowest resistance model first.
75% of their patients are on Medicaid. For some, simply getting to a doctor's appointment can be a challenge.
So if you imagine a woman who is working shift work and has no control over her schedule, she doesn't have a car, so she's bound by a bus schedule. She'll walk in 15 minutes late and they'll tell her she can't be seen that day. She's been sitting on a bus for an hour and a half and is pretty sure she'll never do that again.
Right, when you told me y'all had somebody last week.
And so Grayson and Owen go out of their way to make sure they are available to their patients.
We meet them where they are, both literally and figuratively. We visit many of our patients at home. A lot of times if they have an appointment to come to our office and they don't make it, we'll call them and they're like, okay, are you okay? Do you need us to come see you?
And the commitment doesn't end when the baby is born.
The postpartum care that we provide for them is really, really key. In the middle of the night, they know they can text us or call us.
Alexius Hill still remembers the multiple visits in the weeks after Grayson and Owen delivered her daughter Chloe 9 months ago.
Joey Lynn and Nakia would come by, check on how Chloe would latch on, check on my bleeding, ask me about any concerns that I may have. They made sure that I ate right still, even after delivering Chloe, made sure that I consumed enough water. So even to this point now, it still feels like they're there.
In 2014, the medical journal The Lancet concluded that including midwifery care in health systems reduces maternal and newborn mortality. And a study in the American Journal of Obstetrics and Gynecology found that participating in group prenatal care can reduce the risk of preterm birth, especially for Black women.
When we look at what's obviously different between where we organize our maternal health system and the rest of the developed world, midwives are on the periphery in our country and they're right at the center of care everywhere else. Really, it shouldn't be about like midwives versus OBs. That's really not what it's about. It's about trying to provide women options for care and also ideally access to both.
Grayson and Owen agree and have formed partnerships with Memphis obstetricians, including Dr. Pinkney.
We need the midwives and they need us. If they need a surgeon, if there's an emergency, then we can be there for them.
The norm ought to be providing people with care that's safe and supportive and empowering. We should be able to do all three.
Grayson and Owen are planning an apprenticeship program at Choices to train more midwives of color.
It's a privilege for me to be able to provide care to Black women. When they find me, they are relieved and they talk about that. I think they see in me, they see themselves.
The United States is in the midst of
So there's a lot to unpack in that clip. I would like to begin with talking about what did you find key in that clip as far as the importance of midwifery with respect to Black maternal care and diagnoses, in accommodating mother schedules, in general pregnancy and infant and delivery education. What things stood out for you? Go ahead, Catherine.
Got in the group to help provide the women that were in that group a chance to unload or build the trust that they needed or that they lacked, was really essential in breaking down some of the problems that we were talking about with distress. Being with a group of women and women being honest about what they're feeling is very, very powerful. The voice that they have in that support group is super important. I do have another question, because they kept talking about some of these women really receive Medicaid. What are we doing in Wisconsin? Where is it tomorrow? Are they voting on it? That we are going to accept Medicaid for extended health for people that need it? I don't know. I kept listening to this and the information that was being given, and I want to see where we are right now. And I don't know.
So I'm not certain about that specific question, but when the next clip is playing, I can go online and I'll drop it in the chat. It's a really wonderful resource for our state senators and assembly members, and it tells which committees everyone sits on, what's on the docket, when votes are happening. It gives a description for all of the public hearings. It'll label if it's public or executive session. And for all of the public hearings, they'll tell you where they're taking place and what time. So it's a really good way of keeping track of local topics at the State House. So, yep, no problem.
Amy, it's Sue Conley. I can just fill you in on that specific question. The governor called a special session for tomorrow, but it's my understanding that the Speaker of the Assembly is going to do what he always does when the governor calls special sessions, and that is gavel in and gavel out without any debate. So I don't expect anything to happen tomorrow. I think it's just going to be the normal way it happens up there. But I could be wrong, but that's what the speaker has indicated to us. So,
well, Sue, I hope that you are wrong.
Yeah.
Thank you so much for giving us that update. Mary, I see a question mark in the chat. Is that new or is that old? If it is new, please go ahead and unmute and ask your question.
No, that's old. I did add that I loved the awareness in the clip. I love the awareness of transportation issues. So because if someone is on Medicaid, they probably don't have a reliable car and can't schedule just the way affluent people can try and stick to a schedule.
Important point. Thank you for highlighting that. I see that Katie, you have a question mark in the chat. So we will hear from Katie and then Jen.
Thank you. So I don't know how much things have changed in 10 years since I had my daughter, but I appreciated when they said it's not OB versus midwife, but I feel like there's at least 10 years ago, I was one of the last to go to the Madison Birth Center. And I know there are some in the area, but my impression is to say it's not either or. Well, there aren't a lot of choices for midwives as far as maybe things have come in 10 years, but I'm just curious about that because I personally experienced much greater care with the midwife and experienced just what they're talking about in those groups. You know, they're a lot more willing to sit down and talk and educate and meet you where you're at. So I was just curious Has in 10 years, have things changed? Are there more midwives in the hospitals? You know, and I guess this didn't get into home births, but I think part of the whole implicit bias is that you're more comfortable when you're kind of surrounded by people that you're comfortable with. And when, if you're a person of color, I could understand that, you know, you're surrounded by people with different experiences and biases. I remember reading before about the not being trusted about your pain level as a Black woman. And actually, interestingly, I'm reading the Hemmingses of Monticello right now, and they were just talking about the racism, of course, at that time, and the belief that you know, white women weren't able to do farm work like the enslaved people were, and you know that racism against Black women in particular, compared to white women, you know, you can kind of see it today. So thank you.
No problem. And Jen, before you unmute, so I did a quick Google search of midwives in Wisconsin. And Katie, I'm not sure how many were around 10 years ago, but I just counted 19. Basically as close as Janesville, but out as far as Madison and Milwaukee. Some of them seem to be connected to hospitals. Some of them, by the titles alone, seem to be more independent, but I'm sure have some medical affiliation with a larger medical institution. So midwives in Wisconsin, you can pull up information if that is something that someone would like more information about. Jen, please go ahead and unmute.
Thank you. I guess the one thing I put in the comments, I love the part about the continued aftercare, because just because you have a baby doesn't mean you know what you're supposed to do. I know I called for my aftercare tons of times to ask, is this normal? Is that normal? So that's awesome. And then what Mary touched on about the transportation, that's critical. And I loved how she said, like, meeting people where they're at, literally and figuratively. Because I know, like, with my twins, and for the last 2 months, because I was considered geriatric, I had to go to an appointment every week for 2 months. And had I not been able to get myself there reliably, that would have been really hard. And let alone a quote normal pregnancy that, you know, you're just normal appointment schedule. So I love both of those things.
Right, absolutely. And Jean, I thought I saw you waving your hand, so we're going to come to you in just a minute. But just that community space where women can share with other women is so critically important. And I've been fortunate enough to view that kind of from a couple different vantage points. When I worked for the school district of Beloit as the SAPAR coordinator, one of the things that I was very intentional about was to pull our kids together. I can't imagine being a child and pregnant and or parenting. And every year about 40% of my kids were eligible for McKinney-Vento services. So add that in the mix. And then all of the other racial disparities, et cetera, transportation, you name it. So yes, and then as a parent myself, and I just, in full disclosure, I understand that this was a huge point of privilege, but when we had our first child, I stopped working outside of the home, and we were living in Columbus, Ohio at the time, and I was a part of an incredible group of Black mothers called Mocha Moms, and there are chapters all across the country, and it was a lifesaver just to have this community of Black stay-at-home mothers where you can have play dates and talk, and is this normal? Did this happen to you? What was your experience? Where do I go? Finding pediatricians of color. It did my heart and my mind good. So anytime I can see that women are able to gather and to share their knowledge and lend support, it is a beautiful thing. Jean, please go ahead and unmute.
Well, I think about the experience that my mom had as far as mothers and aunts and a family surrounding her when she gave birth. And I think relationships are just so major, so important. Our daughter Christina is due next week, and I know, and she's in Colorado. I value the fact that she has been able to meet with a doula and develop a strong relationship with her prior to the birth and after. So what you're sharing as far as what really is important for African American moms is also so important for white moms. I just think that it's such a challenge if you feel like you're out there all by yourself and have no support system, no relationships, that it makes the situation much more stressful. It breaks my heart, Amy, to know the statistics for the birth rate, the difference, and giving us each even more of a reason to speak up and continue following that need for change. So thank you.
Absolutely. Thank you, Jean, and congratulations. I'm hoping for a healthy and easy delivery for your daughter. Megan,
Thank you.
Absolutely. I see that you have a question in the chat. Please unmute and share your question or comment.
Hey, yeah, well, I wanted to echo basically what you said about the community piece. And I just wanted to quick reflect on my experience and pose a question. So I was new to Beloit when I became pregnant with my first daughter. And it wasn't until I was 30 some weeks pregnant that I just happened to have had a friend who I worked with who recommended that I switch providers. And I was fortunate to have my first daughter with the midwife at Elkhart at Aurora. And then when my insurance changed with the school district of Beloit, I ended up paying out of pocket for 2 home births because I was not comfortable with regular hospital pregnancy because of, or delivery because of how poor maternal health care is in the United States in general. My own racial privilege aside, had a lot of friends who had horrible experiences in the hospitals. So it's definitely a huge problem. So my question is, when I had my first one, I was fortunate to find a community of women in La Leche League, and eventually like that kind of dissipated, and I had some really great parent friends that I'm still fortunate to be friends with. But it was absolutely, I was like, I'm pretty sure it was all white women in that group. And my kind of 2-part question is, I'm curious if there's what the barriers are, like if there's, that was years and years ago that I was in that group, so I don't know if there's like a stigma or an issue with La Leche as an organization. And my second question would be, I wonder what we can do in our community to kind of offer up a robust mom community, because frankly, I would have been, I suffered from postpartum with my second child. Like I would have been completely lost without the community, Amy, like that you described with like those other stay-at-home moms and people kind of in my own situation. And that's with the privileges that I had. So I guess I was curious about the La Leche piece, and I'm curious about like what maybe infrastructure already exists in our community that maybe we could build on to offer that experience for moms.
So great comment, Megan. I did not prompt her to give us that great segue. So what I want to do is shift the conversation a bit and talking about breastfeeding, because if you are blessed enough to get your healthy baby into this world, you have to figure out how to feed that small human. Gina, I see what you are putting in the chat, and thank you so much. Critical resources, and I love the diversity there. So I just want to go over a couple things before we go to our last video clip. So if as you've heard in the video clips, Black women are 3 times more likely to die as a result of pregnancy compared to white women. Our babies suffer, unfortunately, from infant mortality at a rate that more than doubles that of white children. And often due to low birth weights, prematurity, complications after birth, these are the babies that can benefit most from breast milk. Now, before we enter this portion of the conversation, this is not to shame anyone who chooses not to breastfeed their children because it is not their preference or they are unable to for whatever reason. So I just want to be very clear on that. So I pulled some CDC information, and what I'm about to share, if you're interested in looking it up, came from the National Immunization Survey for Children. There's one for teens, there's one for children. This is the CD National Immunization for Children. And I printed it because the print on the screen was a little bit small. So and this is just talking about in the United States. So women who initiate breastfeeding, and this typically happens immediately after birth, 85.9% are white women, compared to 69.4% of Black women. So that is a racial difference of 16.5%. So that's initiated breastfeeding. So breastfeeding, any breastfeeding after 3 months, the rates for white women are 72.7% compared to 58% for Black women. Exclusively breastfeeding at 3 months is 53% for white women and 36% for Black women. So a 17% difference. And then any breastfeeding at 6 months. So this includes supplementing with formula. So 62% for white women and 44.7% for Black women, which is 17.3% difference. Now, the good news is, if we can get women of color to initiate breastfeeding at higher rates, so this looks at just of everyone who initiated breastfeeding. So 3 months in, for white women still breastfeeding, it's 84.7%. For Black women, it's 83.5%. So just a 1.2% difference. And then exclusively breastfeeding, the numbers are 62.2 and 52.3. And then any breastfeeding at 6 months, for white women, 72.2% of those that initiated breastfeeding and 64.4% of Black women. So if you are able to initiate and you're able to physically continue breastfeeding, the good news is that those numbers, that gap, becomes smaller. Now we can talk about some of the reasons why Black and mothers of color are not able to initiate and continue breastfeeding. So unfortunately, the gap has existed for as long as these numbers have been collected. So for years, the American Academy of Pediatrics has recommended that moms exclusively breastfeed infants for at least 6 months. But CDC studies have shown that hospitals and maternity wards that mainly serve majority Black populations are less likely to help Black women initiate breastfeeding after giving birth and offer little to no lactation support, especially post discharge from the hospital. And we also have to keep in mind that enslaved Black mothers of newborns were first forced to serve as wet nurses and use their bodies to feed white children instead of feeding their own. And this generational trauma can't be ignored when we're talking about breastfeeding. Who gets to breastfeed? What are the barriers to breastfeeding? We also have to keep in mind that Black women in the labor force participate at a rate of 60.2%. As opposed to other women. And additionally, Black women are more likely to be the primary academic support for their family, coming in at 70.7% of Black mothers as sole breadwinners, and 14% of co-breadwinners. So this means that shortly after giving birth, the expectation may mean that you need to return to work. And although in 2010, Congress passed the break time for nursing laws that are supposed to set up these boundaries for when and where women can pump and produce milk and can't be in a bathroom. We know that practically that when women of color exert their rights and demand that employers follow the law, that could put them at greater risk for demotion, for termination, etc. So before we go into the clip, and this is somewhat local, it's a group out of Milwaukee that is encouraging Black women breastfeeding, etc. Is there anything that anyone would like to share before we move into our last clip? All right, I will share my screen.
If the baby will not breastfeed, you need to talk to her. These moms want to improve their baby's health through an age-old yet sometimes shunned practice in African American communities.
It's not typical for a 26-year-old mom to breastfeed their kid, and especially as a Black mom.
Lactation experts say fewer Black women breastfeed their children than whites and Hispanics by about 20%.
It used to be part of our culture, to breastfeed, but slavery and problems, social problems and poverty and other issues happened, just made it much less likely.
The practice was stigmatized generations ago when Black slave women were separated from their own children to nurse slave owners' babies. In modern times, a lack of resources and general knowledge are cited, but Dalvery Blackwell wants to change that.
And the idea is to create an atmosphere where lactation experts, families, fathers, mothers come together to learn ways to have breastfeeding success.
Blackwell co-founded the African American Breastfeeding Network, which holds monthly meetings in Milwaukee. There are similar groups in other cities. They're part of a grassroots effort to encourage breastfeeding.
Infants that are breastfed have lower rates of obesity. They have lower rates of infections.
And lower rates of asthma and infant mortality.
She barely gets sick if she does, it's like a cold or a cough.
Moms benefit too. Some research shows they may have decreased risk for breast and ovarian cancer and possibly heart disease. The American Academy of Pediatrics recommends breastfeeding for at least a year.
Women have an opportunity to see this, how normal and how comfortable that it can be.
While breastfeeding is not a magic solution for all children, there is evidence it can have lifelong benefits. Cindy Sharp, Associated Press.
All right. So that was our final clip for the evening. And before I open it up for discussion, I will just say, speaking as a Black mother, when I made the decision to nurse both of my children, I didn't have that family support.
You are clearly someone who takes care of yourself. So why wait to scream?
Sorry about that. The next clip came up. So no one was opposed to it, but I just didn't have, like, my mother didn't nurse, my aunts didn't nurse. So I didn't have anyone within my own family to kind of turn to. Thank goodness for great lactation consultants. When I delivered Sean, we were in Beloit, so at Beloit Memorial Hospital. I literally was having a meltdown because I was having some difficulty. I called the hospital frantic. The lactation consultant was at her son's softball game. They, for some reason, gave me her cell phone number, to which I called her sobbing. She could barely she's like, I need you to take a breath and calm down so I can help. I'm like, but you're at your son's game, which I knew when I called her. She's like, it is okay. I will walk you through this. And we figured it out. She stayed on the phone with me for about 30 minutes. We got a plan together. She called back the next day to check in. But that support is needed in order to stay in the race and to do this thing that you committed to doing that's great for your kids. But everyone, again, if you are doing shift work and you don't have a place to pump, or there was one clip that I was watching in preparation for this discussion this evening, and it talked about having your children near you helped in the production of milk. And so when people would come over and say, let me take the baby so you can get a nap, or, I'll take the baby and you can go run errands, that one of the moms who was talking was like, I would notice that my supply would diminish. That cuddling and spending time with your child, that's actually like necessary for the production of your milk. So I learned some new things. I was that mom that wanted my children physically strapped to me at all times. So I kind of bumped into that, but I didn't realize that maybe that was a good argument for what I was doing. So I am going to pause. I'm going to open the floor. Comments about nursing and promoting nursing with Black. I will say one other thing. So I'm trying to figure out, why is this not something that Black mothers are doing on a large scale? And as part of the research for this, just the sexualization of bodies in general, but of Black women in particular, and the over sexualization of our bodies when it's time to use our breasts for nursing, that can be very awkward for some people because of all of the messages that we have received. So with that, I will open the floor. If you put up your hand, I am kind of scrolling through, but I am not ignoring you if I don't see you. The best way to make sure that I see it is if you put a question mark in the chat. So if there's anyone that would like to contribute, please go ahead. Kayla, go ahead. I see you have a question mark. All right, I'm not sure if Kayla is still with us. If you're able to rejoin, just put a question mark back in and I will come right back to you. We will hear from Gina, followed by Megan.
Well, I had both of my children and I was in the military. And that just was not very conducive to breastfeeding. We only got, at the time, gosh, this was a long time ago, we only received 6 weeks time off when we had our children. So it was like you were going to get 6 weeks off and then you had to go back to work. And then there were no, I was on a ship. You don't, there was just no way you could, you worked really long hours. There wasn't a whole lot of time to spend with our children, being military people. There was just a lot, and there was just a lot of stress too at the time. So I pretty much just gave up. I tried to pump. It was very stressful. They just wouldn't latch on, and then trying to pump and save it and come home during lunch breaks was just not possible. And just that little bit of time you had to even get them going. I don't know how much of that has changed since I got out, whether you get more time to be at home, but it was only 6 weeks. So that was my reason. So it was work related and I just never was able to do that. I would be curious to learn how many women in the military are doing that, or are they able, have accommodations been made for mothers in the military, to allow mothers in the military to be able to breastfeed, whether it's Black women or any other women. So I'm kind of curious about that.
Gina, thank you for sharing that important perspective that we hadn't heard before. And when you think about, and this is going to sound horrible saying it, I already know, but nursing is such a privilege to be able to nurse your children. And I wish desperately that wasn't the case. Nursing is like a part-time job, and I can't imagine, all of what you just described, and then other barriers that come up. I wish that wasn't the case. Yes, Megan, go ahead, please.
I'll be brief, but yeah, I was just going to point out that my child is nursing right now, so she must have heard you talking. It is like a full-time job. So having said that, I want to talk a little bit about trauma with breastfeeding, because it's something that I think is very uncomfortable for people to talk about, but there are so few resources already, and so few women who have the support to access those resources, who have experienced, whether it's sexual trauma or some other kind of trauma that affects your body, because any kind of trauma can have a physical impact. And I think that one thing, I've been breastfeeding now for almost 10 years, and I have had to actively seek out resources for things like that. And again, I come from a place of many privileges in that area. And so I think one thing, especially with our younger moms, that we lack access to, that can affect, and I don't even want to use the word like successful, because that's loaded, but being able to affect women, being able to breastfeed, for longer periods of time, is just like lack of support and the lack of discourse about it. Because until I became a breastfeeding mom, like that was a completely like unknown world to me. And it's not like you can just jump on Facebook and that's like a ton of resources there. Like you have to actively seek those things out. So I will just say that like just the physical trauma that people have experienced, even sometimes people have trauma just during childbirth that can affect the ability to, sustain breastfeeding, I think is something that we need to maybe bring out more into communities and just normalize and offer women that support and those support groups.
Absolutely. So here's my disclaimer. I didn't read it before I put it in there. But there is a TRICARE maternity care for active duty and separating families. So just some information about benefits and what comes along with that. So if you are interested, please go ahead and click on that link. Carissa, I think you were next. Please go ahead and unmute, and then we'll hear from Mary.
Hi, I want to apologize first. I didn't realize that I was under Kayla's name when I logged in. So that was me before. But I was just thinking, I have a 10-month-old. I breastfed him for 6 months. And I know how hard it was just trying to drag my pump and everything with me to work every day. And when you talk about the women who, have to take an 1.5-hour bus ride just to get to work or get to their appointment or whatever, I couldn't imagine them having to drag along all those bags and everything to take the pump to work, let alone, those pumps are bulky. And I bought one, I bought a travel one, which was a lot smaller, but it was still a lot to carry. And I could see how that could be more troublesome and make moms want to quit breastfeeding if they are, unable to have a car for themselves or so just trying to think of, the privileges that I have and moms that don't have those, how it could be so easy to just throw in the towel for breastfeeding.
Absolutely. Yes. And the problem with the travel pumps is you want something powerful. And those don't always do the trick. Mary, go ahead and unmute, please.
So all these practical things are very important. And I think the history is important too. I've already talked some about history. Looking more at recent times, actually in my own family. So the difference between when my oldest sibling was born in 1960 and my white mother was wheeled into Mercy Hospital and put under against her wishes. It was just like she was a thing. She just was, the doctors knew what to do and she had no say in it. And by the time some of my youngest cousins came along, there were, the La Leche League was very active. They were very in the early 70s, they were able to participate, the mothers, in communicating with the doctors and making choices about their own birthing process. And so I can look at that and say, oh, okay, so there was a lot of change during that time. There was a lot of push for women to become more actively in control of their own bodies. But when I think of all the images that come to my mind from that time, they're all of white women. And they, so it was the women who of the 1970s and then later the 1980s who had the assets and the resources and the time to really devote to pushing back against the established medical opinions of the time, that made the first steps forward. But that doesn't bring everyone along. So it's figuring out how to bring everyone else along. And I'm frustrated to see that we haven't made more progress than we have.
Mary, thank you for sharing. Jen, I see that your hand is raised. Is that new or is that, okay, please go ahead and unmute.
Thank you. I loved what you said, Amy, about it, that, being able to stay at home and breastfeed is a privilege. my husband and I made that same choice for our now 12-year-old son and then the twins. And I honestly don't know how I would have done it if I wasn't at home. And it makes me sad that I had that choice. And my mom and dad basically moved in with us when the twins were born. So that was my job. I tandem nursed the twins for I don't know how many hours a day, but that was my choice. And that was a privilege to make that choice. And I want that for everyone. So thanks for saying that.
All right, so everyone, I did not ask for Jen to provide me that segue either. So we are going to shift slightly into policy. I'm going to share my screen. So I'm not sure if everyone is aware, but there is a Black Maternal Health Momnibus bill. I know Beth took a particular liking to the play on words. So I just want to go through briefly and give you a little bit of information. So the Black Maternal Health Momnibus Act includes a series of 12 bills to save moms' lives and to end racial and ethnic disparities in maternal health outcomes. So this is technically HR 959, Black Maternal Health Momnibus Act of 2021, with the sponsor of Representative Lauren Underwood, a Democrat from Illinois. And I am happy to say that the bill currently has 133 co-sponsors. So I am going to read through these quickly only because I'm not sure of the devices that everyone is using. So if you can see this perfectly fine, just please indulge me. So there's a suite of 12 bills included in the Momnibus Act. So 1 through 4 are listed here. So 1, make critical investments in social determinants of health that influence maternal health outcomes like housing, transportation, and nutrition. So some of those critical areas that we saw in both of those actually all 3 of the video clips. So the second, provide funding to community-based organizations that are working to improve maternal health outcomes and promote equity. So a lot of those organizations that Gina dropped in the chat hopefully will be eligible if this bill is signed into law for additional funding to continue the work that they're doing. 3, comprehensively study the unique maternal health risk facing pregnant and postpartum veterans and invest in BA maternity care coordination. So some of the concerns that Gina brought up as well. And then 4, grow and diversify the perinatal workforce to ensure that every mom in America receives culturally congruent maternal care and support. And I love that this doesn't just say physicians, but everyone in the perinatal workforce. So your nurses, your techs, your blood, everyone that is in the system. So 5 through 8 are listed, improve data collection processes and quality measures to better understand the causes of maternal health crisis in the United States and inform solutions to address it. So groups like the infant mortality group, et cetera, support moms with maternal mental health conditions and substance abuse disorders. So in the second video clip where one of the midwives was saying that, that moms were experiencing having CPS called on them when they expressed feelings of depression. I would assume the same is for substance abuse disorder or any mental health conditions. And those are things that we don't want concealed because those unchecked do not lead to healthy outcomes. 7, improve maternal health care and support for incarcerated moms. One area that we didn't address tonight. It's my understanding that in some births involving incarcerated moms that they are shackled during the process. Number 8, invest in digital tools like telehealth to improve maternal health outcomes in underserved areas. So if you are in a rural area and you cannot physically get to an appointment, that telehealth would be a great benefit. And then closing out this suite of bills, 9, promoting innovative pay modeling to incentivize high quality maternal care and non-clinical support during and after pregnancy. So those partnerships that were highlighted in that second video clip with the midwives, including the doulas and the OBGYNs, is critically important for an approach to holistic care. 10, invest in federal programs to address the unique risk for and effects of COVID-19 during and after pregnancy. Very relevant. 11, invest in community-based initiatives to reduce the level of exposure to climate change risk. We did not address that this evening. And then finally, 12, promote maternal vaccinations to protect the health and safety of moms and babies. So I'm going to stop sharing my screen, but I will find that link and I will put that in the chat in case anyone is interested in reading through the full document or you want to share that information. So I'm going to open the floor back up for discussion of anything that we've covered tonight. We can take a couple more questions or comments. And then I have one brief announcement and I will turn the floor over to my partners, Neil and Beth, to see if they have any announcements from their respective organizations. So final call for questions and or comments. All right, so I found the link to the Momnibus suite of bills. I'm going to go ahead and drop that into the chat. And then Neil and Beth, if it's okay with you, I will go ahead and share my screen and do my one announcement. And then I will turn the floor over to you. All right, there's the link. All right, so it is time at YWCA Rock County for our spring lunch and learn. We take the summer off and then we will come back in end of September with our fall lunch and learn. So our spring lunch and learn is going to be held this Thursday, May 27th from noon to 1. I'm so excited to have Erica Nelson and Stephanie Munoz. Many of you are aware that YWCA Rock County is partnering with Kids Forward to produce the Race to Equity Rock County report. Some of you have probably read the Race to Equity Dane County report. So we are going to have the two authors of that report that are helping us on our report available to kind of give some insights on the process of creating the Rock County report. They will be available to answer questions. The sponsorship for this event is still open. So if you or the organization you represent are interested in sponsoring, please do reach out to me and I can get you that information. I am going to stop sharing my screen, turn the floor over to Neil and Beth. So the final thing I'll put in the chat is the Zoom registration link for our spring lunch and learn. Neil and Beth, the floor is yours.
So will the lunch and learn be recorded, Amy, so people who aren't able to be there can access it?
It will be recorded and we'll put that up on our YouTube channel and Carrie, I think, may still be in the meeting. Carrie is our fantastic new communications director, and she has been doing a great job with helping me with market and not only my programs, but other programs throughout the Y. So we will get that on our YouTube channel and kind of put that on our website so people will be able to easily access the information. But I am hopeful that people can join us live. That way they can have their questions answered in real time.
I just want to report on Diversity Action Team. Diversity Action Team programs take a break for the summer, so I don't have to put Jean on the spot for tonight. So keep thinking about if you have any ideas that you'd like to see covered in one of the Diversity Action Team programs next year, let us know. Jean, me, contact our website or Facebook page, and we can put that in the mix. And now I'm turning it over to Beth.
Excellent segue, Neil. So on a serious note, Community Action has been thinking a lot about the gun violence lately in our communities and across the nation. We don't have anything to announce regarding that, but I just want to let people know that we've been talking about it. And I know that oftentimes people look to Community Action for a response, but we are discussing it in our agency. On a diversity action team note, something that definitely makes me happy, the Nervous Stomachs program from last week. The Merrill Community Sharing Garden was featured, and it is Community Action Month. So if you are looking for the perfect way to celebrate Community Action Month, I would recommend watching this program. I just dropped the YouTube link in the chat. And maybe you can eat some cake and celebrate Community Action Month while reading about the Merrill Community Sharing Garden and learning more about that.
So Beth, if you don't mind, I am going to piggyback onto your announcement about the Merrill Community Sharing Garden. I was so excited during Nervous Stomachs. I was taking notes about the Merrill Community Sharing Garden days where you can go out and volunteer. So listen up, June 5th, July 10th, August 7th, September 11th, and October 2nd. And those are all from 9 a.m. to 12 p.m. Caleb got me so excited. I think there's going to be purple corn, something else he said. And the other thing that was really great, and I am just so excited, and I didn't realize the difference until recently. So in spirit of full disclosure, so the difference between a community garden and a sharing garden, community garden, everyone has their own plots, they do their own thing together, but separately. But in a sharing garden, whatever is grown there, there's always access to the garden. Come take what you need, leave the rest for someone else. And I just think that's beautiful. And one thing that Caleb said that stuck with me is that when things need to be harvested and people aren't there to take them, they'll pack them up in bags. And so if you live in the neighborhood, you might come home to a bag of okra or cucumbers or carrots or etc. On your porch. And I wish that happened to me sometimes. So yes, those are the days where you can go volunteer and probably take a couple goodies home with you. So final call, I am going to put her on the spot and I hope she doesn't mind. I was scrolling through just to make sure I didn't miss any hand raises. I had invited Chelsea Miller, who I haven't seen in a minute. So good to see your name on the call. I am officially putting her on the spot. So I just wanted to be clear about that. Chelsea serves as a doula. So Chelsea, if there's anything, we have a couple minutes remaining that you would like to unmute and share with the group, I would appreciate it.
Hi, Amy. Hi, everyone. I don't have too much to add besides how important of a topic it is and definite confirmation of many of the things that were discussed in the call, in the videos, going on in our own community, and just a lot of work that we still have to do.
Excellent. Thank you, Chelsea, for letting me put you on the spot. It is good to hear your voice. It is 6:59. I am going to pass the torch back to Neil. We will be opening the parking lot. So if you want to stick around and share, that is our unmoderated, unrecorded portion. Neil, the floor is yours to close us out and to open the parking lot.
Hi, one thing I forgot to say earlier is if you want to be on the email list for notification about this, just put your email contact in the chat and I'll copy it down and put you on the list. So here we are, and we don't have to totally stick to the topic if you don't want to. We're just in the parking lot. And who would like to